Hi, this is Brian Kim. I want to share with you case number 154 in the best way to do cataract surgery series. This is a patient with a dense cataract and a small pupil. You're going to see careful disassembly using double chop, cross chop, mechanical fracturing techniques, and learning how to hook lens pieces up out of the bag. By doing it this way, you're able to pull the lens pieces up out of the bag and into the central safe zone, and then using mechanical forces to crush the lens into smaller and smaller pieces, and then using judicious amounts of ultrasonic energy in the central safe zone to remove the lens pieces. This is a patient who had a retinal detachment, and the patient had silicone oil in the eye. You can see the silicone oil bubbles in the conjunctiva. Isn't that fascinating? You see those little bubbles of conjunctival, almost looks like cysts, but that's actually silicone oil. I use a corneal marker, which will help me to center and size the rexus. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some air, and now some trypan blue. I'm going to paint the anterior capsule surface. Again, this is somewhat of a dense lens, limited view, and again, this patient had silicone oil in the eye, post-vitrectomized eye. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. You can see how deep the anterior chamber is. Again, this is a post-vitrectomized eye. And so the good news is with this technique, whether you have a very deep chamber, it doesn't really affect the technique whatsoever. And you can still perform the double chop, cross chop, mechanical fracturing without any difficulty at all. So I puncture with the rexus forceps, pull it towards me, grabbing the right side of the tear to create a flap, going around circumferentially. As you can tell, there's good viscodilation of the pupil with the viscoelastic. And again, it is a fairly deep chamber. Again, post-vitrectomized eye, you can see all of those tiny little silicone bubbles under the conjunctival space. Very unusual appearing silicone oil bubbles underneath the conjunctiva. Finish off the rexus, burp some viscoelastic out. And this is the capsular fornix hydrodissection technique. I place a cannula underneath the rexus edge contra-incisionally. Make sure I go under the rexus edge, point the tip down, get a nice wave. Decompress on the left side, hooking the peripheral lens on the right side, sweeping underneath the anterior capsule with the cannula, and then the lens begins to spin. Irrigating the surface of the eye, adjusting the sleeve. You can see this patient has a little bit of a Bell's reflex. Obviously, this is the left eye as a result. Burp some viscoelastic out, lifting the incision with the chopper, going in with irrigation off to minimize Decimase trauma, removing the surface epinuclear material. You can see that the fluidics is actually causing the pupil to become big, almost like a reverse pupillary block configuration, but I'm going to use this to my advantage so I can have a better pupil dilation. So here we go in slow motion. I have my hand pronated. I'm sliding the tip of the chopper out to the equator, getting underneath the rexus edge, turning my hand, supinating it, so now the chopper's tip is pointed more vertically. I'm turning the phaco tip vertically subincisionally, bringing both instruments together, crushing the central core of the lens in half. That is the double chop maneuver, pronating my hand again, making it flat to the lens surface, gliding it out underneath the rexus edge. Once I get out, I supinate my hand so the chopper is pointed straight up and down again, pulling it centrally towards the phaco tip. The phaco tip is positioned deep between the lens pieces, it suddenly fractures the right heminucleus in half. You saw that sudden loss of resistance, and that is the cross-chop maneuver. I'm able to use some vacuum to lift that first quadrant up out of the bag. And it comes out quite nicely here. And then using the instruments to crush the lens between the instruments, and then emulsifying the lens pieces. And you just want to be mindful staying away from the pupillary edge when you're using the high vacuum or the ultrasonic energy. Since my fracturing and removal of the lens are in separate steps, I'm able to control the vacuum much more easily. So I place the chopper around the second quadrant and fracturing it in half using another cross-chop maneuver, lifting that piece up using some vacuum out of the bag, and then using crushing forces to crush the lens pieces into smaller and smaller pieces, and then emulsifying the lens piece. So again, when I'm crushing the lens, I'm off, but irrigation is on. Once the pieces are small enough and about the size of the port, then I start to emulsify it using some pulses of ultrasonic energy and vacuum. Turning the second heminucleus in front of me, placing the chopper around the lens peripherally, having the phaco tip positioned deep in the bag, bringing the instruments together, crushing and sandwiching the lens, fracturing it completely in half, placing the chopper again around that third quadrant, hooking it from the periphery, and crushing the lens in half. Using some vacuum to pull that piece up out of the bag, again fracturing the lens piece between the instruments, and then emulsifying the lens pieces. The crushing force is the key to this technique. By crushing the lens piece, you're able to break it down into smaller pieces mechanically. And then once you're ready, you can use the high vacuum and ultrasonic energy in small bits to remove the lens pieces. So here's the last quadrant. I'm getting the chopper around it. I have the phaco tip deep, fracturing the lens completely in half. I have that one piece isolated. Again, crushing it into smaller pieces and then emulsifying it. Placing the chopper around that last fragment, again, crushing it in half. You can tell the density of the lens is quite significant. But the beauty is, since you're using mechanical forces, you're able to crush the lens even though it's really dense, and you're not utilizing any ultrasonic energy in the process. Lifting that last piece up with some vacuum, and then crushing it between the instruments, and then emulsifying the lens pieces. So now I'm using some vacuum to start removing the epinuclear material, being mindful that I'm removing every little piece. In this context with a smaller pupil, you always worry about lens fragments falling and flying underneath the iris and hiding. And so it's very important to grab every little small fragment that you see so that it doesn't escape your view. So pretty stiff epinucleus, crushing it and then removing the epinucleus in its entirety. You can see there's some bits of lens material that's stuck in the incision. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the I&E handpiece. I always start sub-incisionally, removing any potential lens material there with the Cortex, and then I peel from anterior to posterior with the maneuver. Switching to polish mode, polishing the posterior capsule. You can see there's quite a bit of posterior capsule fibrosis. Again, this is due to this patient having had a retinal detachment surgery, silicone oil, and that causes PC fibrosis frequently in these post-vitrectomized eyes. I can tell that all of this is just fibrotic material, so I'm not going to be able to polish it off. You can see the unusual red reflex in this situation. Again, trying to polish as much as I can. You can see the reflection of the oil as I'm doing this maneuver. It's not really a red reflex, it's like a white, shiny, silvery, reflectile reflex. Of course, I told this patient she may need to have a YAG capsulotomy down the road if necessary. But of course, the status of the oil is the first priority with that. Push some viscoelastic to fill the capsular bag. Because the pupil is small, I'm not going to really sweep here. I use the metal blade to widen the incision. This is a 3-piece lens. I go in with bevel down. I'm getting caught on the incision there. Again, I have that triplanar corneal incision, which makes it a robust incision, but it also makes it a little bit of a challenge sometimes when I have a tight incision and trying to place the injector through that incision. I finally do it. Turn the bevel to the left. Pushing some more viscoelastic to fill the bag, because with all that maneuvering and pushing, I caused a lot of viscoelastic to burp out of the wound. Advance the leading haptic into the bag. Before I let it go out all the way, I'm going to use a Maltzman to make sure that as it comes out, it's going to go into the bag. So the Maltzman helps to ensure that the leading haptic's in the bag. As the optic comes out, I pronate my hand and the optic comes out flat. And then I'm going to try to dial that trailing haptic into the bag. I'm inspecting with the Maltzman, and it looks like it's in good position. I go in with irrigation off, activate irrigation. Carefully with irrigation on, I go underneath the lens optic, removing the viscoelastic from within the bag. I'm pretty confident that the haptics, both haptics are in the bag. Switch to polish mode, but of course it's such a small pupil. It's going to switch to visco mode, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a small pupil, dense cataract, post-vitrectomized eye. You can see those weird-looking conjunctival cysts. They're not conjunctival cysts. That's actually silicone oil bubbles underneath the conjunctiva. It almost gives the eye almost like an unusual alien scales appearance. But this patient also has silicone oil. You can see the atypical reflection of the red reflex, which again makes it a little bit more challenging if you have a technique like divide and conquer, which depends upon that red reflex. But with double chop, cross chop, mechanical fracturing, even with a small pupil, no problems. Even with a deep chamber and reverse pupillary block in this post-vitrectomized eye, no problems. The double chop and cross chop work very, very well in that context. And I'm able to disassemble the lens very confidently and efficiently. Again, this is somewhat of a dense lens, but I'm able to use mechanical fracturing forces, bringing the lens pieces up out of the bag into the central safe zone, crushing the lens pieces into smaller pieces before emulsifying them. Again, challenging case, a lot of potential for things going wrong, but because I'm confident in my technique, I know where I'm at, I'm able to fracture the lens within the capsulotomy opening using mechanical fracturing forces, opposing forces to crush the lens, and using that opposing force to crush the lens confidently in all different directions. Double chop, cross chop, mechanical fracturing principles. This case is really just a routine case, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.